A 42-year-old man comes to the office due to a skin rash on his left lower extremity. A month ago, the patient noticed several purple spots on his left calf that have progressively enlarged, but are not painful or pruritic. He has no chronic medical conditions, but has been treated for primary syphilis and anal gonorrhea. Temperature is 37.2 C, 98.9 F. Blood pressure is 136/82 mmHg, and pulse is 86/min. Physical examination shows 3 purple-colored elliptical papules measuring 1-2 centimeters on the left lateral calf. HIV testing is positive. CD4 count is 45/mm3, and HIV viral load is 45,000 copies ml. In addition to antiretroviral therapy and treatment of the skin lesions, which of the following is recommended for this patient?
Okay, so already I'm thinking the diagnosis is going to be, I forget if it's called like angular papillomatosis, like something sarcoma, Kaposi's sarcoma. That's going to be my diagnosis. His CD4 count is less than 50, meaning we have to treat with prophylactics. So probably like all of these. I don't know if this changes our differential in treatment or changes our treatment plan, but this for sure does. We're going to have coverage for Toxoplasma gondii. Probably this is covering MAC, Mycoplasma avian complex, prophylactic this, not sure. Oh man. Do you have to be on prophylactic villus aciclovir? Okay, so we're definitely gonna eliminate, we definitely need to be on TMP SMX for sure. I would just put him on azithro as well. Fluconazole? That's tough. I don't know. I don't see necessity here. Ouch. Okay, so I got the diagnosis right of Kaposi's sarcoma. Patients, let's see.
All patients with HIV should generally be initiated on antiretroviral therapy, regardless of CD4 count. Additional treatment is then indicated based on the degree of immunodeficiency and serologic testing as follows. CD4 count 200/mm3, primary prophylaxis, treatment prior to disease onset against pneumocystis pneumonia is required. Daily trimethoprim sulfamethoxazole is the drug of choice. CD4 count 100/mm3, primary prophylaxis against toxoplasmosis is required in those with positive toxoplasma serology. Daily trimethoprim sulfamethoxazole is also effective against this disease. Hepatitis serologies, hepatitis A and B virus vaccination should be given to those with no evidence of immunity. Treatment is required for those with chronic hepatitis B and C infection. Varicella zoster virus serology. Vaccination is required for those who have never had chickenpox shingles and have negative serology.
Gotta be careful against that though, but let's see what else we got.
Vaccination against pneumococcus and influenza is also indicated. Primary prophylaxis, itraconazole against histoplasmosis is sometimes given for those with CD4 counts 150/mm3 in histoplasma endemic areas. Egg, Ohio, Mississippi River Valley. In the past, primary prophylaxis, egg, azithromycin against Mycobacterium avium complex MAC, was given to those with CD4 counts 50/mm3, but this is no longer recommended due to the low incidence of MAC, particularly once antiretroviral therapy is started.
Okay. No longer recommended. Okay, I get it. You're trying to teach me that we don't give prophylactic azithromycin for MAC anymore. It's pretty on the money with everything else. Fluconazole, I was like, yo, fuck it. Aciclovir, I don't even know how to pronounce that.
Although patients with advanced HIV are at increased risk for candida, egg, oropharyngeal thrush, and cryptococcal infections, Fluconazole primary prophylaxis is not recommended due to cost and increased risk of azole drug resistance.
Really? I mean, like, I'm okay with that. I just want to know. So I guess there's really only one prophylactic, and that's TMP-SMX for HIV. Let's see. Yeah, and then okay.
1, 2, 3. 1, 2.
They really like to do me dirty.
A 45-year-old man comes to the emergency department due to left wrist pain after a fall. The patient was walking in his house when he tripped over a rug and landed on his outstretched hand. His wrist swelled and he applied ice, which did not improve the swelling or pain. Medical history is notable for celiac disease, hypertension, and hypothyroidism, for which he is on thyroid hormone supplementation. The patient does not use tobacco, alcohol, or recreational drugs. He has no known medication allergies. BMI is 20 kgm2. Examination shows a dinner fork deformity at the left wrist. The wrist is swollen and tender to palpation. Sensation over the left hand is intact, and the patient is able to move all his fingers. X-ray of the left wrist is shown in the image below.
Okay, so honestly, celiac is a huge one due to malabsorption, for sure. Hypothyroidism can have hypocalcemia. I'm torn between the two. Let's see. Honestly, though, I mean, it says here he takes thyroid hormone, so yeah. Yeah.
Osteoporosis in a young or middle-aged man suggests a secondary cause. Bone loss is common in celiac disease due to malabsorption of vitamin D. Manifestations may include asymptomatic osteopenia, osteoporosis, or osteomalacia with bone pain, muscle weakness, and impaired ambulation. A 28-year-old woman, gravida 1 para 0, at 37 weeks gestation comes to labor and delivery for induction of labor for severe polyhydramnios. The patient's 20-week anatomy ultrasound showed a male fetus with a tracheoesophageal fistula and a posterior fundal placenta. She developed increasingly severe polyhydramnios, with her most recent amniotic fluid index measuring 39 centimeters, normal 24. The patient has been receiving an oxytocin infusion and is having painful contractions every 3 minutes with a Category 1 fetal heart rate tracing. She has a sudden gush of copious clear amniotic fluid immediately followed by heavy vaginal bleeding and constant abdominal pain. Temperature is 36.7 C, 98 F. Blood pressure is 130/80 mmHg, and pulse is 118/min. Fetal heart rate tracing shows a baseline of 120/min and minimal variability. Togodynamometer shows contractions every minute. The uterus is smooth, gravid, and tender to palpation. The cervix is 5 centimeters dilated and 100% effaced with the fetal vertex at +1 station. Which of the following is the most likely cause of this patient's acute presentation?
Bro, I don't, this, what? I don't know. OBGYN's like for sure my worst subject.
This laboring patient with sudden onset heavy vaginal bleeding and abdominal pain immediately after rupture of membranes has abruptioplacenty, the premature detachment of the placenta from the uterus due to bleeding at the udero-placental interface. Patients with uterine overdistension, egg twin gestation, severe polyhydramnios are at increased risk for abruptioplacenty because the sudden uncontrolled loss of amniotic fluid causes rapid uterine decompression, which shears maternal placental vessels and causes placental hemorrhage and separation. The bleeding also increases intrauterine pressure, which causes constant pain, a rigid, tender uterus, and uterine irritability, high-frequency contractions. As more of the placenta detaches, fetal perfusion progressively declines and can lead to hypoxia. Therefore, patients with persistent bleeding and an abnormal fetal heart rate tracing, egg bradycardia, minimal variability require urgent delivery to prevent fetal demise and maternal complications. Egg hemorrhage, disseminated intravascular coagulation.
I mean, she's at 37 weeks though.
Abruptio placendae is the premature separation of the placenta from the uterus prior to fetal delivery and typically presents with abdominal pain, vaginal bleeding, high-frequency uterine contractions, and abnormalities on the fetal heart rate tracing. Uterine overdistension, egg twin gestation, severe polyhydramnios, is a risk factor. Normal labor progression is characterized by contractions that cause cervical dilation, and often spontaneous rupture of membranes, however. It would not cause acute onset of pain and minimal variability.
Interesting. So they're saying during labor labor does not have an acute onset of pain, and there's minimal variability. Okay. Like, I kind of get what they're getting at, but I'm like, okay.
A newborn girl born at 37 weeks gestation after an uncomplicated vaginal delivery is evaluated due to poor tone of the lower extremities. She is not moving her legs and does not respond to heel prick. Deep tendon reflexes are 1+ in the lower extremities. Cervical spine range of motion and upper extremity examination are normal. A hemangioma is present over the midline lumbosacral area. APGAR scores were 7 and 9 at 1 and 5 minutes, respectively. Which of the following is the most likely diagnosis?
This sounds about right. No way she had an infarct. Dude, it might just be cerebral palsy. Dysraphism. I was thinking some sort of like spina bifida. Yeah, bifida occulta. Yeah, that's basically what that was. I think it's like there's like a hemangioma, it's actually kind of more suggestive of something like it's like a more intense. It's like a hydrocephalomyopathy, some weird name. Yep.
Closed spinal dysraphism,
I guess they have a new name
spina
now.
bifida occulta, is due to failed fusion of the vertebral arches. Symptomatic newborns can have cutaneous manifestations, egg, lumbosacral hemangioma, on the lower back and/or neurologic deficits due to tethered cord syndrome. Neurologic manifestations include lower motor neuron signs, egg, weakness, hypotonia, hyporeflexia, sensory loss. An 8-year-old boy is brought to the emergency department 45 minutes after falling out of bed. He had been asleep for about 10 minutes when his mother heard a thud and immediately ran to his room. She found him unconscious on the floor with a blue discoloration around his lips that resolved after a few seconds. The patient regained consciousness after a few minutes, but seemed excessively sleepy. He has had no fever, vomiting, diarrhea, or change in appetite. The patient has no chronic medical conditions and takes no medication. He was drowsy but responsive on the drive to the hospital and was able to walk in unassisted. Vital signs are normal for age. The patient is now alert and interactive, but does not remember anything about the event. Which of the following is the most likely diagnosis?
Bro, what? 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 Oh yeah, immediate? Okay. Nobody just passes out and then they're just like, oop, we're good. I guess some people do. Not everybody does.
Seizure should be considered in any patient with an episode of sudden loss of consciousness followed by a postictal state of sleepiness and confusion. Other common findings include perioral cyanosis, evidence of tongue biting, and urinary incontinence.
Really? Perioral cyanosis. Well, shit. Did he pee himself? Like, I mean, if he peed himself, I'd be like, easy clap, but what the hell is a breath holding spell? I just imagine these kids like being like, yo, how am I gonna try to like ruin my parents' day to day?
Breath holding spells occur in children aged 6 months to 5 years and present with either cyanosis or pallor. Pallid breath holding spell following physical or emotional distress. Although a period of confusion can follow a pallid breath holding spell, This patient's age makes the diagnosis unlikely.
Come on, that's BS, bro. If the patient's age is the only thing, like a seizure though, come on. Weird.
One, two. A 3-year-old boy is brought to the clinic by his father due to fatigue and pallor. The patient was seen in another clinic a week ago for abdominal pain and diarrhea. A medication was prescribed to help slow the diarrhea, which resolved, but the patient has been much less playful over the last day. Temperature is 36.7 C, 98 F, blood pressure is 110/70 mmHg, pulse is 120/min, and respirations are 20/min. Physical examination shows an uncomfortable appearing child with scleral icterus. Cardiac examination shows mild tachycardia with no murmurs. A few ecchymoses are noted along the upper and lower extremities. There is pitting edema along bilateral lower extremities to the knees. The remainder of the examination is unremarkable. Laboratory results are as follows.
Okay, so that's all normal. Within normal limits. You didn't say within normal limits. You just said normal. I don't know whose voice that is, but I hear you, bro. Okay, so he's got like fucking sickle cell. Yeah. Let me just wait. Okay, well this could be schistocytes. I can't rule that out, but that looks like a sickle. Yeah, they look sickled. That's normal. Could be schistocytes. I don't know. I don't know. That's nothing. I would just go with. Kind of looks like schistocytes. Fuck. Just, I mean, Oh, are they trying to say ITP? TTP? ITP, TTP would be... There's a pitting edema. Nah, dude, this gotta just be like sickle cell, right? Yeah, come on. Oh, yeah, HUS? And it is schistocytes. Wait, what? Oh, right. Bro. Wait, where's the bloody poop? Guess it's not bloody. Often bloody. Wow. Just wow. Bro, I did not know. I'm pretty sure. I could have sworn that goes up. The PT and PTT. Wow. Okay, so fuck me. Fuck you. AKI. Didn't give us creatinine. Just gave us edema. Okay. Oh, choice C was sickle cell? Yeah, I guess. So is thalassemia and shit. Bless you. Whatever. Damn. I mean, should I have made the diagnosis? Yeah, I guess that my diagnosis... I wouldn't have been able to say what his acute state was. I was actually thinking it was more of a reaction to medications. I was actually going to say something. I don't know. I just kind of saw that and I was like, that's a sickle, right? That could be schistocytes too. I mean, we got it.
57-year-old man comes to the office due to involuntary shaking of his hands. It started on the right side, but now his left hand shakes also. The shaking disappears with purposeful activity and worsens with emotional stress. The patient does not have a family history of tremors. Physical examination shows a fine resting tremor in both hands. There is some muscle rigidity of both arms. Gait and posture are normal. Cognitive function is normal. Which of the following is the most appropriate treatment for this patient?
Damn it. Decreases? Bro, what? Interesting. Improves with activity. Now, when you say, let's see. Yeah, no, intention, like tremor, like that improves with activity is like kind of vague because like the way that it was worded is that basically there's a resting tremor that gets better. That gets better when he tries to do something, intentionally tries to do something. I have no idea what trihexafenadol is, but I'm 100% sure that's the second time I've seen that, so now I have to memorize that. That would be tough. Yeah, but they're only going to get older.
Parkinson's disease. PD should be suspected in patients with an asymmetric resting tremor that is associated with rigidity or bradykinesia. Trihexafenadol is an anticholinergic medication sometimes used in the treatment of PD, generally in younger patients where tremor is the primary symptom.
Improves with alcohol. That's kind of cool. Let's drink, boys. Get this essential tremor going. Gone.
Which of the following is recommended for this patient? A 20-year-old woman comes to the office for a refill of oral contraceptives. She is in a monogamous relationship that began 6 months ago and uses condoms as backup contraception. The patient became sexually active at age 14 and has had 5 lifetime partners. Her last menstrual period was 2 weeks ago. She has regular menses lasting 4 to 5 days every 28 days. The patient has not received the human papillomavirus, HPV vaccination series, and has never had a pap test. 3 months ago, she had negative screening for sexually transmitted infection. The patient has no chronic medical conditions and has had no prior surgery. She smokes cigarettes socially but does not use alcohol or illicit drugs. Vital signs are normal. Physical examination shows normal external genitalia without any lesions.
Damn it. I thought that was HPV testing. I was just going way too fast there. But I know, actually, wait, did she never get the HPV vaccine? Yeah, she did not receive. Okay, so obviously that would have been, I would have gotten that. That would have been easy. But I could tell you, like, HPV vaccination, it's basically any time before you're, I want to say like 24, 26. Okay. We'll keep that as the thing. But vaccination may be given up to this age. Catch-up vaccination. What is catch-up vaccination? I know what it is, but I just mean, like, what is it for HPV? Is it like, do you just inject them 8 times at once?
A A 32-year-old man comes to the emergency department due to a persistent nosebleed lasting an hour. Over the past week, he has had several episodes of epistaxis that stopped after prolonged nose pinching. The patient has also noticed more fatigue and skin bruising than usual over the past month. He has not had any recent nasal trauma or upper respiratory tract infections, and does not use any intranasal medications. The patient does not use tobacco or alcohol and maintains a vegan diet. Temperature is 37.2 C, 99 F. Blood pressure is 130/80 mmHg. Pulse is 96/min, and respirations are 18/min. Physical examination shows dried blood in the right nostril with no intranasal lesions. No enlarged lymph nodes are present. Lung fields are clear to auscultation, and heart sounds are normal. The abdomen is soft and non-tender with no hepatosplenomegaly. Scattered ecchymoses are present on the extremities. Laboratory results are as follows.
Okay, so for like a 32-year-old, that could present as like ALL. And if that's ALL, that's like maybe these. Oh, I could be this. Yeah, I mean, he's definitely in DIC, and I know like acute promyelocytic leukemia often induces DIC. So like that's the only thing I know. His age suggests to me that it would be like an ALL. I don't see what else would trigger in the history. He's got a vegan diet. Is that enough? Like serum B12? Like, nah, like I don't think that does shit. Anyways, what else? Yeah. Cool. Yep. Yo, absolutely fucking collaged. Big association. I literally just had a question, and it was like, acute promyelocytic leukemia caused DIC, and like, what are all the things? And so, the things were increased, decreased, and then it was like a history of acute promyelocytic leukemia, and then he has DIC, which can be illustrated by the ecchymoses, anemia, thrombocytopenia, actually just fucking pancytopenia, really. Next step to establish
Which of the following is the best
diagnosis.
next step in establishing the diagnosis?
Okay, so like I don't think any of those do. Oh wow, really? Okay. I was gonna say like we're gonna need a biopsy, bro,
to the clinic
for the
due to a
diagnosis.
3-month history of intermittent hand stiffness and pain. She has also felt excessively tired and has had occasional episodes of knee and sharp chest pain. The patient takes no medications and does not use tobacco, alcohol, or illicit drugs. Temperature is 37.2 C, 99 F. Blood pressure is 130/70 mmHg, and pulse is 80/min. Bilateral hand joints and wrists are mildly tender and swollen. Lungs are clear to auscultation, and heart sounds are normal. The abdomen is soft and non-tender with no organomegaly. There is mild bilateral lower extremity edema. The patient has no rash or lymphadenopathy. Laboratory results are as follows.
In a 23-year-old, Jesus Christ. She's not on any medications, right? Yeah, so it can't be like histone, I think, because that would be drug-induced lupus. Rho would be Sjogren's. This would be diffuse. This would be rheumatoid arthritis. And this would be like Wegener's or the other one. You used to know, whatever, but it's probably RA. Fucking cunt. What? Oh my god, bro. You need an Anna to establish? Oh my god, she has SLE? Get fucked me. Yeah, I guess that does make sense because she's like a little bit younger than when RA would present. But like if... Yeah, so why... Wait. Oh, well, yeah, because we would need anti-Smith. Yeah. And, okay. But like, how am I supposed to know this is SLE? The age? Symmetrical? That's also in SA? Sharp chest pain? I mean, bitch could be anxious. Fatigue? Mild cytopenias? Okay, you're starting to get me. Protein losing neuropathy? Okay, that actually, now that you mentioned that, yeah, you know, she could have some sort of like, I forget if it's called like diffuse proliferative or nephropathy, but get fucked me. All right, I got you. Fair enough. Fair enough. Dude, initial eval? No way, bro. You didn't even put an Anna in here. Bro, I'm throwing an Anna on everybody I see that like fucking... if I smell autoimmune, I'm throwing an Anna on that bitch. I feel like Anna's just not good enough though. It's too non-specific, and like the way that it was worded was like diagnosis. I guess the fact that I saw biopsy as not one of the answers should have like told me it's like we're not looking for the specific answer, the best answer, sir. All right.
The medical director of a busy primary care clinic is leading a quality improvement project aimed at reducing the patient no-show rate. The director is planning to implement a telephone and text messaging reminder service that sends a message to patients 1 day prior to their appointment, prompting them to confirm their appointment or reschedule.
Okay, so I know this is like proactive. Near miss is like, nah, yeah, whatever. This is possible. That's my second one. So like, I like this one because it's proactive, right? But they want to systemically assess the reminder system's effectiveness. Well, you're gonna need like... See, like pre and post system surveys, whatever, don't fucking matter because it's as simple as you need to know whether or not these motherfuckers are showing up or not. This is proactive, like, assessments to identify problems, but like, I don't know about that. Yeah, okay, perfect. Run chart. I like it. I like charts. Wait, why did I mark this? Okay.
The medical director tracks monthly no-show rates for 18 months following implementation of the reminder system. A run chart is constructed comparing no-show rates prior to and following system implementation. As shown below, which of the following conclusions is most closely supported by the trends seen in the run chart?
I mean, this is probably... This is like a better answer. Like this is like, yeah, it does do sufficient improvement, but it's not like the better answer. Because that's like too like absolute.
Which of the following is the most likely diagnosis in this patient?
Ooh, fun.
A 62-year-old woman comes to the office due to 6 weeks of malaise and intermittent fever. She has also had decreased appetite and unintentional weight loss, but no bowel or bladder symptoms.
Cancer.
The patient has a history of type 2 diabetes mellitus and hypertension, and 10 years ago she underwent total hysterectomy and bilateral salpingo-oophorectomy for early-stage endometrial cancer. She has smoked a pack of cigarettes daily for 30 years and does not drink alcohol.
Lung
She
cancer.
works as an accountant.
Pancreatic
Temperature is
cancer.
37.9 C. 100.2 F. Blood pressure is 140/90 mmHg. Pulse is 90/min, and respirations are 16/min. On examination, she appears thin and pale. A hard mass is palpated over the right flank area. There is no abdominal tenderness, and bowel sounds are normal. The liver and spleen are not enlarged. No lymphadenopathy is present. Laboratory results are as follows.
I mean, actually, maybe, but I don't know what the hard mass would be. What, like, fucking... Not wait, bro. She does have a mild fever, but that wouldn't explain the unintentional weight loss. Right flank area? Jeez, I can't even imagine an appendiceal abscess that does it that bad. If it's a lymphoma, get wrecked. How could it be anything other? Come on.
A 25-year-old woman is evaluated for occasional episodes of palpitations. She describes the episodes as a sudden, abrupt onset of fast and regular heartbeats that feel like her heart is racing in her chest. The episodes are commonly unprovoked and are not related to exertion. During one episode, her blood pressure was recorded as 100/60 mmHg, and her heart rate was 185/min and regular. She has no significant past medical history and does not take any medications. She has no family history of heart disease. Physical examination is unremarkable, including no heart murmurs or additional sounds. She also reports that she has been self-treating by immersing her face in cold water during the palpitation episodes. Generally, she says, cold water immersion relieves her symptoms abruptly within several minutes. This maneuver terminates the palpitations by directly altering which of the following?
I really want to say something like that. Okay, so like let's say cold water on the face triggers... Bro, I don't know what the fucking... I really don't. I think... Okay, if there's... Oh, what kind of fucking sense... Oh. A cat cut me yesterday. I just noticed a little scratch here on my body. Cat scratch disease. Somebody give me some azithromycin.
This patient's clinical presentation, abrupt onset of regular tachycardia that resolves with cold water immersion, is consistent with paroxysmal supraventricular tachycardia, PSVT, atrioventricular nodal reentrant tachycardia, AVNRT, is the most common form of PSVT and frequently develops in young patients with a structurally normal heart. Palpitations are the most common presentation, but some patients may have dizziness, shortness of breath, or chest pain. AVNRT is due to the presence of two conduction pathways, slow and fast in the AV node. Normally, sinus beats are conducted in an antegrade direction through the fast pathway. As antegrade conduct... Vagal maneuvers, carotid sinus massage, cold water immersion or diving reflex, Valsalva maneuver, eyeball pressure, increased parasympathetic tone in the heart and result in a temporary slowing
eyeball
of
pressure right
conduction in the
now.
AV node
Shit.
and an increase in the AV node refractory period, leading to
Sounds
termination
nice.
of AVNRT.
Also known as like just an eye massage. You just rub your eyes, kind of like you have something. You're, you know, like you've got seasonal allergies, so you gotta itch your eyes, but you shouldn't be itching your eyes. Oh, that's nice. My fucking My AVNRT is gone. That's nice. That's nice. I like that. I like that question. I learned something new that I liked.
A 26-year-old woman comes to the emergency department due to weakness and numbness in both arms and legs that has progressively worsened over the last 3 days. The patient has no fevers, headache, dizziness, chest pain, shortness of breath, or abdominal pain. She reports no trauma or recent procedures. The patient has no medical conditions and takes no medications. She does not use tobacco, alcohol, or illicit drugs. Temperature is 37 C, 98.6 F. Blood pressure is 130/82 mmHg. Pulse is 88/min, and respirations are 20/min. On examination, the patient has 4/5 strength in both upper and lower extremities. Sensation is decreased below the neck. MRI shows increased T2 signal in the cervical spinal cord without any mass lesions or compression. Intravenous administration of which of the following is the best next step in management?
What's unfortunate is, like, this could be GBS, right? I don't know what kind of shit does this, though. Maybe, like, she's got multiple sclerosis, maybe? ALS, some BS like that, but honestly, she has no fever, which kind of, like, in my opinion, reduces all that shit. So we're down to, does she have GBS, in which case we give her immunoglobulin, IVIG, or is she having some sort of multiple sclerosis episode and we should give her corticosteroids, right? So that's your decision. Now, can you give both? I think you could give both. Let's see. Is there... Right on T2. It's got to mean something, man. It's got to mean something. Thanks. If it is GBS... If it is GBS, oh man, IVIG. We give IVIG. Do we give IVIG? Or is it plus or minus IVIG? The only differential is right here, the T2. Increased T2 signal. I don't know what the fuck increased T2 versus T1 means. Fucking, because I'm stupid. Oh my fucking god, bro. Progressively worsened. Okay, so let's just go with GBS. In which case, steroids, right? And then plus or minus IVIG. Yeah, fuck it. Idiopathic transverse myelitis, you bitch. They're gonna give me idiopathic. Wow. Oh, okay. ATM. Okay. Just the problem is they don't know. Oh. Yeah. Interesting. Yeah. Yeah, I knew that. But like, come on. This is like scary. Definitely admit, you know? Definitely admit to the hospital. Transverse myelitis. Wow. I'm pretty sure you could totally give them like corticosteroids too. Yes, it's IVIG plus or minus corticosteroids then. Bro, if they have fucking the autoimmune though, you know you're giving steroids. Like, who the fuck isn't giving steroids? Name one time we ain't gonna give steroids in an autoimmune condition. Or an acute autoimmune condition. It's not like diabetes. Okay, what's the next best step? Got it.
A 24-year-old woman, gravida 1 para 0, at 37 weeks gestation comes to the office for a routine prenatal visit. The patient has no concerns today. Her fetus is active, and she has no contractions, vaginal bleeding, or leakage of fluid. The patient's pregnancy was dated by a first trimester ultrasound, and her 18-week ultrasound revealed normal fetal anatomy. At 26 weeks gestation, her 1-hour glucose screen was abnormal, but her 3-hour glucose tolerance test
So
was
she's
normal.
fine.
The patient has no medical conditions and has had no surgeries. Blood pressure is 112/68 mmHg, and pulse is 90/min. Fundal height is 42 centimeters, and fetal heart rate is 138/min. Because of the uterine size dates discrepancy, an ultrasound is performed, which reveals an intrauterine fetus in the cephalic position with an amniotic fluid index of 30 centimeters normal, 8-24 centimeters.
So my best guess is maybe the dating was a little bit wrong. At 37 weeks, we ain't gonna give anything other. Oh wait, so if it's wrong, I'm just gonna go with the kid is too fat. Damn. Okay, well, the kid may have been too fat. Oh, is that what it means? Oh, okay. All right. So we're learning polyhydramnios is defined as amniotic fluid index of greater than 24 centimeters or a deepest vertical pocket of 8 centimeters. Got it. So that's what they were trying to give us with the amniotic fluid index. That's what they were trying to suggest, polyhydramnios. But due to the fact that she's asymptomatic, they can have expected management. Interesting.
Which of the following is the best next step in management of this patient?
Loop.
A 62-year-old woman is brought to the emergency department by her family due to dizziness. She was unable to get out of bed and go to the bathroom this morning and has had headache and nausea. The patient has a history of migraine headaches and hypertension.
Yikes.
6 months ago, she had an episode of transient right-sided vision loss and was prescribed aspirin. Other medications include amlodipine and hydrochlorothiazide. Temperature is 36.7 C, 98.1 F. Blood pressure is 156/72 mmHg, and pulse is 88/min. BMI is 33 kgm2. On physical examination, the patient moves all extremities, and deep tendon reflexes are symmetric. CT scan of the head is shown in the image. The patient is admitted to the hospital. An hour after admission, she appears lethargic but follows simple commands. She had a single episode of vomiting in the emergency department.
That's bad. Yeah. They gotta drain it. I had a stroke patient. All I know was neurosurgery got in there before I even saw her. So, fucking surgery.
A 15-month-old boy is brought to the emergency department due to irritability and vomiting. His parents say that the patient was more tired than usual yesterday and went to bed early. This morning, he awoke crying and has been inconsolable. His mother attempted to feed him, but he has vomited twice today. 3 weeks ago, the patient had similar symptoms and was admitted to the hospital and diagnosed with enteroviral meningitis. He has a history of 2 episodes of pneumonia requiring hospitalization as an infant. Temperature is 40.1 C, 104.2 F. On examination, the patient is awake but crying and inconsolable in his mother's arms. Heart and lung examinations are unremarkable, and the abdomen is soft. There is a diffuse macular rash over the trunk. Lumbar puncture results are as follows.
Yeah, well, Gram-Stein's going to do bacterial, so... I mean, I don't... I have no idea what the fuck that is. Damn it. He has X. Fuck me, bro. There's no way I could have known that one. Like, give me this, and I'll be like, for sure, for sure. Yeah, yeah, yeah. Easy clap. But, ooh. That's a good differential right there. I wouldn't have gotten that either, though. Fuck me, bro. Fuck me. Oh, this shit hard. All right, one last one.
If the treatment for the disease is safe and inexpensive, which of the points labeled on the graph represents the best diagnostic cutoff for the disease?
Oh. Probably D, because it's safe and ineffective. So all the disease-free people will get got. So I think I'm thinking. So like it, you know, it's like it's lethal if untreated, and it's safe and inexpensive. So we want to basically treat everybody, right? But we don't want to miss. We don't want to miss one of these motherfuckers. I'm trying to think which one it is. Now the question is, if we set it here at D, that means everybody that's positive, everybody that's, oh, no. We would want to set it at B then, because everybody that's positive and has the disease would be picked up. Let's go. Easy clap. We'll end it on there. We'll end it on a win. We rarely end things on a win, so